Still after yeah, so good afternoon, everyone. This is Brandon with NMQF. Obviously, I'm here. We do these webinars. We try to educate or say edutain uh, you guys for about an hour on some topics really important to healthcare, health equity. I'm in DC on this rainy day, but I'm really excited to have our three speakers. One, Donney John, who you all know as our advisory board chair for NMQF, and then Doctors Freeman and Priscilla, because I'm just ignorant on how it's properly pronounce your last name. And I've also known Brandy since she was in undergrad. So the two Dukies on here, and then the St. John's guy. So very basketball oriented group right now. But they're going to talk about the impact of Medicaid cuts. And obviously, I know that these people, by all the commas behind their name, are much smarter than I. And it's just one way to tell. But I'm going to go ahead and turn it over to Dr. John, who's going to moderate today's panel.
Thank you, Brandon, and thanks for having us all join you on Friday. I'm really looking forward to the discussion with both Dr. Freeman and Dr. Maspey to really give us insights in terms of what's happening with Medicaid and then specifically how it impacts children. So I'm going to pass it off to Dr. Maspey so she can provide some words of wisdom to all of us.
Dr. John, thank you so much, and good afternoon, NMQF and attendees. Again, my name is Dr. Priscilla Posse. Sounds like a cowboy posse, but not to be affiliated with the Dallas Cowboys since we started with the sports team there. I am really excited for this enlightening webinar. We've talked a lot about, I'm sure, in our own circles and professional spaces about impacts to Medicaid, and it's really important that we ensure that we're talking about the impact to all populations, particularly children. Pleased to be joined by my fellow pediatrician colleague, Dr. Brandy Freeman. We're going to be speaking from different lenses, from a federal lens, a state lens, a patient lens. We are going to have a few slides because we want to show you really just the landscape of where Medicaid is, and we're still hoping, again, have the dialogue about potential questions on what we might see at the state level and then how our patients are going to be directly impacted. So Dr. John, I'm going to go ahead and share a few slides here, and I'll look to you to let me know when they are visible, and we will jump into the dialogue.
Yep, they're visible. And before you start, just want to let the audience know, if you do have questions, please drop them in the Q&A box, and we'll answer the questions throughout the presentation.
All right, fantastic. So I'm going to open up our dialogue today, really talking about our changing landscape. We are all aware that there are discussions about potential Medicaid cuts and changes to the program. And what does that look like? And I'm going to be speaking from my lens as a population health officer at Christiana Care, particularly the medical director for our Delaware Medicaid partners, and also as a pediatrician. So I do want to note that the presentation today really reflects my own views and my experiences and my research within Medicaid network adequacy, not representative of Christiana Care Health System, particularly, though does bring light the experiences that I've seen in Pennsylvania and Delaware. So I will be speaking about like what is Medicaid. We all know Medicaid as the insurer or the payer. I'm really going to focus on the program structure so that way we can unpack what the potential impacts would be from an implementation standpoint. Again, pivot to how Medicaid plays a role in children, and then what are the considerations that are being proposed. So let's start from the federal landscape. The hope is that most, if not all Americans, but that all persons have access to health insurance. And there's different types of health insurance. If we think about the marketplace, about 20 million persons in the country have service through the marketplace. And then we see next is Medicare. So we generally think about Medicare for our elderly population serves just under 48 million persons. Then there's also military insurance, generally TRICARE. So those who have served our country are serviced through a military insurance program, just under 5 million. But if we see in that green, Medicaid serves almost 70 million people in this country. I listed CHIP there. That's the Children's Health Insurance Program that is implemented at the state level, specific for children. The conversation today will focus primarily on Medicaid, but it is to show that Medicaid is the largest health insurer supported by federal funding, again, covering almost 70 million people in the country. So what is Medicaid? So it is the primary program and largest source of funding, providing comprehensive coverage of healthcare and long-term services that supports for people with low income in the US. And I do highlight the income aspect because that is one of the eligibility or criteria to be able to be served by Medicaid. Additionally, it is the largest funder of substance use treatment, the largest funder of mental health services, It plays a critical role in rural areas, particularly in rural hospitals for access, plays a critical role in pandemics and epidemics. It's important to note that Medicaid, again, provided the largest funding when it came to COVID activities, particularly with testing and vaccinations. Medicaid was instrumental during the initiation, or state initiation, but during the initial outbreaks of HIV, Ebola, avian flu, SARS. Medicaid is generally the largest funder to access health and activities at the local and state levels. Additionally, it covers more than 60% of nursing home residents, and it covers nearly half of all children, knowing that almost 1 in every 2 child in the United States is covered by Medicaid. So who's eligible? First, it's by income. It is set by the federal poverty level. And so the minimum eligibility for children and pregnant women are set at 133% of the federal poverty level. So for those that may not be familiar, what that FPL is what I'll refer to is if you have a family of 3, that income level would be $35,630. And that's set for 2024. The 2025 FPL will be coming out shortly. So for any family of 3 that is making that income or below would be eligible for Medicaid. And then that is adjusted. There is a ratio adjustment for individuals and then larger families as well. And then as of 2023, so giving context of the change over the past couple years, we think about the median eligibility. So right in the middle, what is that average? Children that were on Medicaid were actually living at a federal poverty at 255% below the federal poverty level. So that gives us a sense of just the poverty landscape and the income gap in this country. And then the median eligibility for pregnant women was at 207% below the federal poverty level. So we talk about children being vulnerable. We know pregnant persons are vulnerable. And then, of course, those living in poverty have greater vulnerability when it comes to social determinants of health. So Medicaid plays an important role in so many aspects. So when we think about Medicaid expansion, most states are expanded. Who's now eligible? So we talked about low-income children, pregnant women and persons, parents of Medicaid eligible children, low-income adults who do not have dependents, low-income persons with disabilities. So someone that receives SSI is also eligible or is on Medicaid, and then low-income persons that are 65 years and older. So I've mentioned briefly Medicare. We think about that E for elderly. Patients 65 years and older eligible for Medicare. Depending on their income level, they can also receive Medicaid as well. So how is it delivered? There's actually a joint federal and state program, which is why this conversation is really bubbled up and expanded when it comes to federal cuts, because the dollars are dispersed from the federal level, and then they are administered to the states, and the states are responsible for administering their own program. Now, when we think about the funding, the federal department provides the funding, and the states actually have matching dollars. So both the federal and the state contribute to that program. And that's through a program called the FMAP, the Federal Medical Assistance Percentage. And so what that means, there's a percent of Medicaid expenditures that the federal government will pay the states, and it's actually a 1-to-1 match. So you could say for every dollar that the federal government puts in or every dollar that the state puts in, it will be matched by its partner. And that federal match rate is set at a baseline of 50%. So you could imagine, again, if the state has a $100 contribution to Medicaid, the federal government is matching that at $100. Now, there is equity in the FMAP, right? So for states that have a lower per capita income, or we can say the term for states, right, where income levels are lower or there is wider poverty, the FMAP rate can actually be higher, up to 77%. So that's really important when we think about equity across the country, that there is mindfulness that in areas where there are lower resources or lower dollars, the federal government will actually provide a higher match. And then for some groups in the ACA expansion group, it's actually financed a 90% federal match rate. So why am I spending time on this area? Again, it's to note that if there's a reduction of dollars from the federal level, then there would have to be a reduction of dollars at the state level. I want to show this schematic. Depending on where you are in the country, and just wanting to highlight DC, we know that many of our attendees and colleagues are coming to DC for the NMQF Summit. When we look at DC, very small there to note, right? It's in the pink. It is one of the areas that's about 50 to 55% of the match rate of the FMAP. As we get into the darker colors, those are the states that have a lower per capita income across the state. Want to note that Mississippi actually has the lowest income per capita income, and so they do receive the highest FMAP rate of 77%. Why is that important? So if you cut federal dollars, the state dollars will be cut almost at that same rate. So those states would actually experience a greater loss of funding. So you could look at that map and see where your state is and determine what your FMAP rate is. So want to also talk about Medicaid funding in general. We know that there is a large GDP when it comes to healthcare. And when we talk about our healthcare dollars, Medicaid actually represents 1 out of every $6 spent on healthcare in the United States. For the past 5 years, as we talk about state budgets, right, the past 5 years, Medicaid funding actually represents somewhere between 16.8 to 29% of that state budget. So for a state, they could be seeing that Medicaid and those federal dollars represent 25% of their entire state budget, very low. When it comes to state budgets, we think about education, transportation, police, healthcare. Generally, Medicaid is second in state spending after elementary and secondary education. So now we're starting to see, right, where that impact could come to children. And then reminding again that as Medicaid is the largest source for federal funding for healthcare, it also represents the largest single source of federal funds for states. Let's look this up in the pie graph as we show here in that blue where that arrow is. If we look at states, and this is on average, we see that 56% of a state's budget is coming from Medicaid dollars. So imagine if we now cut into that pie, it's going to now adjust the other funding allocations that states have. We see next in purple, that's an actual dollar or line item budget allocation, is K through 12 education at 10%. Then we see higher education, public assistance, transportation, all others lumped into that 23. So if we start to cut into that pie for Medicaid, states will have to reallocate, and there's concern that K through 12 education would be the first to have impacts there. And this is where I'll pause here to again really show, when we look, I mentioned all of those persons that are able to be covered by Medicaid. Look at the enrollees. Again, we're about, if we're including children, adults, and our elderly population as well, about 94 million around in 2021. We can see at the top of that, that children again represent the largest population of enrollees on Medicaid, 34%. However, they represent the smallest spend. So we can all do basic math. More people, less money. If we cut into less money, more people are impacted. So really, really wanting to highlight that. And this is why it was so critical. We're so appreciative to have this conversation about the impact specifically to children. So I want to take a pause there, see if there's any questions in the chat. Dr. John, just what are some thoughts that may have come up from that opening part of our dialogue before we really get into the aspects around children?
Well, thank you for giving a lot of great insight and background on the topic of Medicaid. You know, we have learned from history in terms of most recently with the Medicaid expansion during COVID and the subsequent unwinding that it's caused a lot of people losing coverage. So can you elaborate in terms of what were the significant impacts on health access and patient well-being due to Medicaid unwinding since the pandemic?
Yeah, that's an excellent question. And we could find like a dual impact here. So fortunate, right, that our elected officials recognized that because of COVID, we wanted to make sure that all patients had access. So we saw a large uptake or an uptick in patients that are enrolled. A benefit is that I talked about enrollment. So enrollment generally is verified every year. It's 12 months from the time of your first enrollment. So if you enrolled in December of 2021, December 2022, you're due for renewal. They'll do a verification, review paperwork, eligibility, and so forth. During that period of during the height of the COVID pandemic, I will say, there was not the renewal process. So there's what we call a continuous enrollment, that all patients who had been on Medicaid or had started to receive Medicaid at the time maintained their enrollment through that period. And so as the landscape started to shift, state Medicaid departments were then required to start doing their eligibility checks. And so Dr. John, as you mentioned, the unwinding, right, it now then many Americans, adults, children in particular, were actually faced with the fact that they would then lose their Medicaid coverage. And so the greatest reasons for loss actually were administrative. Families could have moved. They didn't have contact updates. They were no longer eligible because of the federal income level criteria. And so that was the initial loss in terms of those who had coverage, from 2020 through 2023, we're now losing Medicaid. So we found that those who were going to primary care appointments or being able to be seen in an urgent care for an appropriate issue were no longer able to do that. We saw drops in primary care coverage, drops in children's wellness visit, drops in vaccination rates. And so we have greater concern is that more people will now lose their coverage and accessibility, and we'll continue to see, particularly around prevention, those services decreasing as well.
So another question to build off of that is, you briefly touched upon the aspect of someone being duly eligible. So what does it mean when you have Medicaid and Medicare, and what's their implications for their health coverage?
Yeah, so someone that's dual eligible is meeting at least two of the requirements from each of the payer programs. We tend to see dual eligibility more on the Medicare side. So again, to be eligible for Medicare, something that we keep in mind, so Medicaid ends in D. Generally, it stood for destitute. Of course, we now have more patient-centered focus, and we say disparities. So patients who tend to have greater disparities are eligible for Medicaid. And then the E, Medicare, for elderly, so 65 years and older. We do recognize that there are some elderly patients who may be low income or low wealth. And so based on their income level, they would also be eligible for Medicaid. So what that does is it gives them wider coverage. Generally, Medicare will cover Part A and Part B, which is your primary care specialty services. If you need additional coverage, right, or additional payment support, Medicaid will be able to cover that. So it allows our elderly population who may be more vulnerable or at risk for social determinants of health impacts to receive that coverage. So they too would be impacted through this. And I'd mentioned, again, Medicaid covering more than 60% of like nursing home residents. That's a population we need to be critical to. Dr. Freeman, I don't know if there's anything else to add. I know you've been looking at the state level, but we don't really do a lot of duals when it comes to Medicare and Medicaid. So
yeah, no, I think from a state perspective, I think is for children. We don't see quite as many, but wow. There.
So remember, if anyone has any questions, please put them in the chat or in the Q&A box, and we'll make sure we answer them along the way.
okay. Great. So really hoping that set the stage when we think about the Medicaid program, federal dollars going to the states. There is a match rate, that FMAP. So again, that's a partnership that we're seeing, federal and state working together to ensure that states have the dollars to provide coverage to those who are eligible to be enrolled in Medicaid. We have to think about our children and mention they represent a wide population of our Medicaid enrollees, but of small spend. So what's going to happen to them if we see some of these proposed cuts? So Medicaid, from our lens, Dr. Freeman and myself, it really is the foundation for our pediatric healthcare system. Close to 50% of children in this country are Medicaid enrollees. There's great support for our children's hospitals. I'll go into that a little bit deeper. It's the foundation for our pediatricians, subspecialists, and health professionals, both from a care delivery standpoint, but also a training standpoint as well. Educators and child programs, right? So we know that educators interface with our children throughout the day. Child programs, after school programs, supplemental nutrition assistance program, women's and infant children's program. There's a lot of interface there with Medicaid. And then families and caregivers. Our children are in the safety net, so to speak, or they're cared by their families and caregivers. And so parents, caregivers, grandparents want to ensure that their children are getting access, and Medicaid provides that. So it really intersects through a lot of aspects of the care delivery. Our children rely heavily on Medicaid. I mentioned 1 out of 2, but really that number is 37 million children in the United States. In many states, 50% or even more of Medicaid enrollees are children. It covers, again, 4 out of 10 children. And when we think about children who are living in poverty, it covers 8 to 10 children. When you think about children with special healthcare needs, covers almost 1/2 of the population. So when you mentioned about 37 million children on Medicaid, About 12 million children in this country are living with a special health care need, and Medicaid covers about 6 million of those children. Covers 1 in 3 children diagnosed with cancer. We ensure that, Medicaid, anyone on Medicaid is able to receive the same access as someone on a different type of insurance plan. And that includes our children with cancer or with significant illness. And then for children who may be hospitalized, Medicaid covers children hospitals inpatient services at a high level. I want to show this a little bit more. So when we think about our children's hospitals, and again, I'll reference Washington, D.C., we have Children's National that's here in the D.C. area. If I go up 95, just staying on our East Coast here in Delaware, Nemours Children's Health. In Pennsylvania, we have Children's Hospital, Philadelphia. These hospitals receive a significant amount of funds and also execute their care through Medicaid funding dollars. We see here that that represents about 55%, and our Children's Hospital Association is continuing to do a lot of work and data analysis on that, where they're projecting that in some states it's even as high as 60-65%. Then when we look at private insurance or private funding, that's at 38%, and then other non-government or government spending makes about 5%. So you can see simple math there is that with impact to Medicaid dollars, decreased funding, that our Children's Hospital would have to incur a significant burden, even to the point where they may not be able to deliver care to all children. There's also Medicaid supplemental payments, right? So Medicaid at baseline, right, is providing payment or reimbursement to our clinicians, but Medicaid dollars are also allocated in other ways as well. So you may have heard the term DSH, disproportionate share hospital payments again. So if there's a service that is not fully covered or not fully reimbursed, there are DSH payments that will cover those costs, particularly for patients who are uninsured. So Medicaid provides gap coverage in that sense. There's upper payment limits. So in some states, I said that the states actually run their own programs. If there's a service where there is a lower payment out for that service, could be a dental procedure, could be setting a broken arm, the payment is low, there's a UPL that can actually offset that so that the payer or the hospital or the practice can receive the payment that's needed. GME, I talked about training. Dr. Freeman and I, clinicians, Dr. John, right through his training as a pharmacist, right, are going through our educational programs or going through hospitals. And Medicaid actually provides that training. So if there's cuts, we're concerned that that will actually impact our workforce. That could be a part 2 or part 3 of this conversation. 1115 waiver payments, it allows for states to implement innovative programs or initiatives that can provide additional payments. Again, it can also provide gap coverage for funds, particularly for aspects that are not covered in that regard. So states would have limitations on how dollars could be allocated. And then directed payments, so this would be to practices or providers directly. So I spent some time on this slide to say that we generally think about Medicaid or any insurance program as patient goes to access care or care is being delivered and there's a payment. But thinking about all the way that funding and dollars are spent in the healthcare system, Medicaid impacts a lot of these aspects. So let's look at coverage by the numbers with children. Again, we're holding on that number. About 37 million children are covered by Medicaid. It covers 40% of births in this country. And I do want to highlight, particularly with the start of National Black Health Awareness Week through April 17th, right? We know that there are wider gaps, particularly in Black maternal health. And so ensuring that there's equity in funding and care delivery there. 40% of mental health. We recognize, particularly in the height of the COVID pandemic, that children were being significantly impacted. We've seen higher rates of depression, anxiety, unfortunately starting to see higher rates of completed suicide, community violence. So 40% of children are receiving mental health services. Medicaid covers 43% of children living in immigrant families, and many of our families are concerned, or some are not even showing up to get care. Medicaid covers 46% of children living with a special health care need. Medicaid covers almost all children. Currently, right now, 99% of children in our foster care system. And this is a population where children in the foster care system can actually stay on Medicaid through the age of 26. And most importantly, Medicaid covers 100% of medical services. What are those services? We call them EPSTD, so early periodic screening, diagnostic, and treatment. So there are benefits. right? So anyone that's been the fortune of being on health insurance, when you go to your primary care for your annual physical, right, it's covered. There could be a co-payment, right? Medicaid is actually providing full coverage. All children under 21 are able to receive services. The states will provide access. The states will cover the amount for medically necessary services, and states have the opportunity to cover what we say optional services. Those optional services are deemed medically necessary by the physician or the provider. Dr. Freeman will tell you that most times we would say that all of these services are necessary. So children that's enrolled by Medicaid are receiving all of these services. We'll not go into each of them in detail, but you can see the snapshot. So it's seeing your clinician, getting an x-ray. If you're hospitalized, it's covered. Nurse midwifery, again, important thinking about our maternal health services, medications, dental services, glasses. All of these are covered through the Medicaid program for our children. I want to show here, this is a little bit of an older schematic, and I mentioned that our Children's Hospital Association is looking into new data, but it's important when we talk about Medicaid network adequacy that a child that's enrolled is able to have the same outcomes as a child on a different payment plan. And so when we look at the green, that's like an employer or private health insurance, and we look at Medicaid in the orange, which is that payer, and then those that are uninsured. And we can see across the board here that children on Medicaid have pretty equal or in close proximity to the outcomes of those on an employer insurance, which is important to know, right? As compared to those who are uninsured. And I'm going to come back to this. We also, don't know there. Also want to make note that children enrolled in Medicaid miss fewer school days, talking about education, are more likely to graduate from high school, grow up to be healthier adults, and earn higher wages. So Dr. Freeman and I oftentimes will say, you're welcome to adults, right, that are 18 to 64, because pediatricians are involved in that. We want to make sure that all children that are currently between the ages of birth to 17 have that opportunity to also grow up to be healthier adults. So when we think about Medicaid cuts on the table, we've heard from our Senate budget resolution that includes $1 billion for the Committee on Finance, and we're $880 million. That should be $880 billion coming from the House budget. And so if that were to occur, what does that actually look like? If there's less federal funding, that means the states are going to have to take on that funding, or if the funding is not available, there would be those cuts. So we're concerned that there could be block grants, right? So there's one lump sum that the states have to implement. There could be per capita caps, which means that they would limit enrollee to a certain number. That FMAP rate, which we talk right now is at 50% or 77%, like states for Mississippi, would be reduced or even eliminated. There would be no matching dollars from the federal government. Minimum rates would also be reduced as well. And then also provider tax, right? So this allows for provider to recoup additional funds that could be reduced or eliminated as well. So states, how will states respond? They want to make sure that patients are still covered. Children need to be able to go to the physician, school enrollment, and so forth. So this could be tax raises that would be on tax-paying citizens like you and myself, or like myself and you all that are watching this webinar. States would have to cut budgets or do reallocation, and we know that that would start with K through 12 because that's the largest part of the state dollars. There would be deep cuts to the Medicaid program, and this is what's leading to these potential harmful policies. So I'm going to set this part up here to transition to Dr. Freeman. When we think about the patients, is that if we see the policies, what would the patients feel? So there could be waiting lists to get enrolled on Medicaid. They could limit the number of people who are enrolled. There could be time limits to say maybe you could only be on Medicaid for 3 years, or some lifetime limits as well. What's really concerning is they may bar people from being able to roll for what I say non-compliance. If you missed your renewal period, if you didn't submit document on time, that now you're no longer eligible to apply or receive Medicaid. And so we get concerned about this exclusion level. They would restrict eligibility, and then they would start to target the population coverage. And this is where we're concerned that children would be at the greatest impact because they're also not eligible for the other insurance programs like military or Medicare. And so we're concerned that some of the EPSD benefits will become optional. They may eliminate mandatory benefits. They may close the drug formulary. Dr. John, I'm sure you've seen that in your area, right? If we're not able to, prescribe widely, it would narrow options for medication selection or delivery. Some services would be excluded, and it also raise out-of-pocket costs for those families. So what we want to avoid is that the children who are currently enrolled on Medicaid do not start to resemble the children in blue that are uninsured. And so this is why this advocacy is so important, why conversations like this are critical. And so I want to leave you all with this as I transition to Dr. Freeman, is in many cultures, particularly in the African continent, there's a greeting. This is using Swahili, Hasirian Ingera, which means how are the children? And that's a way for the community to really emphasize that how the children go is how the community and the adults go. And so it's important to say Sapati Ingera, the children are well. And so it's really up to us as clinicians, as health professionals, health advocates, to make sure that the children continue to stay well so that our community overall is well. So I am going to turn it over to Dr. Freeman, though Dr. John, I want to see first if there's any other questions in the chat, or again, any thoughts that may have come up from this section.
There's no questions right now, but I think there's going to be a lot of questions once Dr. Freeman is able to provide that state perspective. So thank you for setting the stage, Dr. Maspey.
There we go. I think, no, we're not good on slides. We're good on slides now. All right, good afternoon, everyone. It's a pleasure to speak with you today. My name is Brandy Freeman. I am an associate professor of pediatrics at the University of Colorado School of Medicine and a National Academy of Medicine State Health Policy Fellow for this year. I'm going to be giving a perspective that really focuses on what we might see for children, looking at different things that have happened at the state level. I think Dr. Posse has given us a fantastic introduction in terms of what Medicaid is, what this might happen with children. And I'm going to try to look into a crystal ball a little bit and talk about a couple of policies that we've seen at the state level and how those could impact actual children through clinical examples. So as we move forward, animation is so fun. There we go. Just a couple of disclosures. I want to make sure that I make it clear that these perspectives are my own. They are not those of the University of Colorado School of Medicine, the National Academy of Medicine, the National Medical Association, nor the Colorado Department of Law. So what do we know? As we think about what might happen with Medicaid, one of the things that's on the table, and I think most likely to be cut, is Medicaid expansion. We've seen, although Medicaid expansion was primarily designed to help uninsured adults afford insurance, it has been shown to be significantly impactful on child health. For example, between 2016 and 2019, states that expanded Medicaid saw decreases in the rates of uninsured children, while non-expansion states saw increases in the rates of uninsured children. So if you go back to the slide that Dr. Posse showed you in terms of the impacts on child health, when you expanded Medicaid, you got better outcomes. And when you didn't, you began to approach those worse outcomes. In Oregon, for example, this expansion showed a welcome mat effect. And this is where people who were previously eligible for Medicaid, children specifically in this case, were actually enrolled at Medicaid at a higher level due to the expansion of other adults into Medicaid. So if a child's parent was suddenly eligible for Medicaid, that also got the child enrolled, and overall saw better improvements on health for the entire family. So expansion also showed improvement in perinatal and maternal health. We saw increased preventive care use, decreased incidence in child neglect, decreased high school dropout rates, and overall a 50% decrease in infant mortality. And I think that's really key to think about. One of the phrases I love to say is that pediatricians are in the practice of making thriving adults, and we have to have overall impact, good child health and children who are staying alive in order to make that happen. We saw that children with cancer survived longer in states that had Medicaid expansion, and that you had better outcomes in cancer when you had Medicaid expansion. So this is overall showing the broader effects of this coverage. So when we look at the states that did expand Medicaid, it's about 41, including the District of Columbia. There are 10 who have still did not proceed with Medicaid expansion. And as we're looking at the outlook for states, we recognize that those states may not see as many changes, but there are several, the majority of our country, that will see a significant impact on the health of their people, the health of their children related to Medicaid expansion. And then when we look at what that rate could do when we look at overall what that change in the expansion of the FMAP that Dr. Posse was talking about, that we see that this rate could change between 19 and 49% across expansion states, and so causing a significant impact on the health of our populations. So we know that these Medicaid cuts may take many forms, that it could be work requirements, it could be changing the match rate, it could be capping funding. I think the key point here is that shifting costs to states and taking away coverage for people with low incomes is going to lead to worse health outcomes. Some people, while it's being described as Medicaid cuts or cost cuts, I think what the important thing to think about that these are actually cost transfers. Many states are not going to be able to just neglect the health of their people, and it's going to be transferring these expenses to the states. When we think about capping the enrollee spending, this is a study that the Kaiser Family Foundation did. And when they looked at it overall, I think the key point to see here is that no matter what kind of format you saw in terms of what the rates or the actual policy was that was going to change, the children were impacted at the same level, about 20%. And so this is going to be a reduction that we're not going to be able to overcome just by ignoring this issue. So now I want to take some time. I call this my crystal ball section of this. And so while we don't know exactly what is going to happen with Medicaid and how each state might proceed with this, there are a couple of examples I think that can show us clinically what this could look like and give us great examples in terms of what are states potentially thinking, what is the potential risk in terms of what is on the table currently with regards to Medicaid. So we'll start with first talking about a case, John. So John is, these are cases taken from my clinical experience. I guess I should have actually said at the beginning, I am a practicing pediatrician. I see a population of patients that is about 85% Medicaid. So seeing a significant number of children who receive the services of Medicaid, whose lives are benefited by having Medicaid, and I am quite worried could be negatively impacted by the potential cuts that could come with Medicaid. So John is a 2-year-old male. He was born to Sudanese parents. Excuse me, timing is interesting. Born prematurely at 30 weeks, and he was born at a low birth weight. His father does seasonal work and like house painting and lawn care, and his mother works at a local grocery store. John was born with a heart murmur, and that is being followed by our cardiology team. He also has gross motor delay and speech delay. Given that his parents are not citizens and their jobs do not provide insurance, he has infrequently received medical care because of issues with being able to afford it. So let's just spend a little bit of time understanding what happens with children of immigrants. So first of all, in our country, 1 in 4 U.S. children has a U.S. immigrant, in the U.S. has an immigrant parent. And when this look like for health, children who are children of people who are not citizens are more likely to be uninsured. So 4% of children who have citizen parents are uninsured. If you have one non-citizen parent, that goes up to 80%. And if you're a non-citizen child, it's actually up to 25% in terms of uninsured. Dr. Posse also already explained to us that you have worse health outcomes when you're uninsured. So what has one state done? So Colorado, for example, has come up with Cover All Coloradans. This was enacted. It began in January of 2025, and it was part of Colorado's Medicaid expansion effort. This expands coverage of Medicaid to children and pregnant people, regardless of their immigration status. So making sure that their people are able to receive healthcare and receive care that they need. So with regards to John, what has happened? Because of Colorado, for all Coloradans, he's actually able to receive healthcare. He's been able to receive primary care. He's been able to receive specialty care and receive all of the things that EPSDT does offer to him. So we've seen an improvement in his health. But what is on the table? So, I'm sorry, my slides keep moving on their own. My apologies, another step. 1 second, let me pause the share, resume the share, see if I can go back. There we go. So because this is a Medicaid expansion effort, what could happen? Because this is a Medicaid expansion effort, he could potentially lose coverage. Coverall cotton runs is at risk in the current Medicaid funding environment. And for John, that would mean a loss of care. Once again, not being able to have his heart murmur taken care of, not being able to receive the specialty services like speech therapy, physical therapy, occupational therapy that he needs. And I believe, if I remember our script correctly, we're supposed to pause at this point in time. So, Dr. John, I'll turn it over to you.
Dr. Freeman, question, in the case of John as a patient, what's the potential for exceptions to be made in order to make coverage, and also to build off of that, in terms of charity care, a lot of hospital systems provide charity care as a core benefit in their community. So how would someone like John, in his scenario, how could he get exception or exemption in the future, but also would he be eligible for charity care through the health system?
So I think he would be eligible for charity care, but I think we have to remember that children's hospitals are also funded by Medicaid. And so with a significant amount of their funding being at risk with these Medicaid funds, there's a chance that even their charity care would be limited. And so I think we could see the potential. Unfortunately, we're losing crystal ball in some regards right now, but the impact kind of rolling over into each other in terms of Medicaid going away and then actually impacting the funding of the hospital, having then an impact on charity care. I think we could see kind of a shaking of the foundation of pediatric care, which is really quite frightening to me. I think if there are no other questions, I'll go on to our second case, which my slides were trying to do anyway. So let me get right back to that. So our second case is Brielle. And so Brielle is a 5-year-old female. She lives in a single parent home with her father. Her mother died soon after birth due to eclampsia. She has asthma and epilepsy. She's had 7 emergency department visits in the last 2 years due to either asthma or epilepsy. And 6 out of those 7 have been due to her being out of her medications because of a loss of Medicaid coverage. So let's spend a little bit of time talking about the evidence of Medicaid coverage gaps for children. So we know a child with any coverage gap has a higher likelihood of having unmet medical, prescription, and dental needs. They have a higher likelihood of having no usual source of care, no doctor visits in the past year, and then having a delay in urgent care. And when we compare those coverage gaps to children without coverage for longer than 6 months, those children had a higher likelihood of having unmet needs compared to children with shorter gaps. And this actually can even approach the level of being worse than having been uninsured. So one state, Pennsylvania, actually has proposed something called Keystones for Health of Pennsylvania. This is actually a Medicaid Section 1115 waiver. I remember Dr. Posse spoke a little bit about those in terms of some of the other parts of Medicaid. And this was something that was approved at the end of the Biden administration for Pennsylvania. It focused on 4 areas: reentry care, housing, food and nutrition, and then for this case, multi-year continuous coverage for children under 6 years of age. And so this means children would not have to go through the administrative burden of having to reapply or requalify for Medicaid each year. They would be able to keep their Medicaid until they were age 6. So with Brielle, she would be able to receive continuous coverage through this policy. It would allow for her to receive care that she needs to optimize herself, to stop the medication gaps that she's had, to decrease the emergency room visits, and make sure that she's able to thrive and be a healthy child. But as we know where we are right now, there are challenges to this policy right now. This waiver is actually being challenged within the state of Pennsylvania, and this, should it go away, would result in Brielle continuing to suffer the ill effects of gaps in her Medicaid coverage. So could put her once again in a difficult situation where she's not receiving optimal health. So just a few references. I want to close with just saying, I think it's really important that as we think about Medicaid and where it's going, that it's important for us to look at the unique things that states have been able to do because of Medicaid expansion. I think it's something that has allowed our states to innovate and really take care of their people. And when we look at what the federal system is trying to do right now and how that could be transferred to states, I think we should be worried in every state of this union of what this is going to look like.
Thank you, Dr. Freeman. And a question to kind of bring things together is that when children reach the age limit for Medicaid, what pathways exist for them to maintain health coverage, and how have states facilitated the transition? Because illness doesn't end once you turn 18. So if you had a seizure disorder or asthma, like the patient Brielle in your case, once she reaches adulthood, what happened? What's the next step in terms of her journey?
So I think that's one of the scariest things. For some children, there may be possibilities of transitioning if they are working themselves by the time they turn 18, if they have parent coverage. The marketplace from the Affordable Care Act can be an option, but for many low-income families, those aren't easy options, I guess I would say. And so I think it's a reason to be concerned that having a child be at a certain level of health and then transitioning to worse health overall, I think is a not only a threat to their personal health, but our overall society, if we're not going to continue to promote health for individuals.
Thank you. So I have a question for both of you. In terms of the economic consequences when the Medicaid funding reductions occur, how is this going to contribute to the expansion of medical deserts? We talk about medical deserts and health disparities, maternal deserts, all sorts of deserts, but specifically with these Medicaid cuts, what's going to happen?
I can hop in and start. I think one of the things that we're going to is those increasing. I think in terms of how hospitals are funding, how healthcare is funded, there is a significant interaction between Medicaid funding and that. And if hospitals are not able to operate, if primary care practices are not able to operate, we're going to see worsening for deserts, worsening issues with related to access to care, and I think overall worsening health of the American population.
Yeah, and I will add that then what do those deserts look like, for our neighborhoods, our schools, our communities? So, children can't get into care. That may delay school enrollment. Why would that delay school enrollment? They didn't get their physical, or they're now behind on getting their school required vaccines. I actually experienced this yesterday. I had a family come in. There's a process of transfer of guardianship. Unfortunately, the child's 7. Her mom experienced an illness and died last year from complications and is now in the care of grandparents. And grandparents are going through the process for legal guardianship and are applying for Medicaid. So unfortunately, there's a gap in coverage. They are trying to enroll her in a new school that's close to where they live. She came in yesterday. We were not able to see her because of the gap in coverage, and the school is not yet ready. She cannot enroll in school because she doesn't have an updated physical and they can't verify vaccinations. I mean, that is literally what we see. So that's one child. Imagine amplifying that exponentially. We could talk about the pathway of vaccines. If children are not getting vaccines, what does that look like for communicable or preventable disease? We're starting to see some of that occur. It could be something that is as, I won't say simple, but as basic as managing allergies or asthma that could be managed by home daily medications. Now you can't pick up your medication. Children are getting more sick, then they have to now be seen in the ER. So it's going to be worsening health outcomes, but that's going to put a strain on our emergency room systems, where now I worry that there's going to be lines around the block because people are trying to get in for care somewhere. So I think the concern is that people think about this like in a nebulous way, like, oh, there's going to be cuts and then there'll be like an impact. But you can actually reach on like touch patients, right? And actually see what is going to happen. And the irony that I saw this yesterday just made me think about, this is patient 1 of how many could this be in the next months or years to come.
You bring up an excellent point in terms of how this is real, how real people, real families are impacted. And it makes me think about the issue of caregiver burnout. It is very heartbreaking as a parent to see your child suffer. So in terms of with Medicaid cuts and children losing access to coverage, what is it going to do in terms of that rising caregiver burnout and the stress that's going to cause for families?
Yeah, I'll start with that. It's an excellent question. I mentioned, and Dr. Freeman referenced this as well, right? Is that children are in the care of adult caregivers, right? Whether they're immediate parents, grandparents, aunts and uncles. And so standard, we saw this a lot in COVID. Child gets sick, child needs to be in the care of someone throughout the day. So that's first. We talked about caregiver burden, right? But that's just starting with the day-to-day employment. Some parents don't have the fortune of having, paid time off or sick leave. So they're actually having missed days of work because now their child is sick, where again, if they'd received care earlier, that may not have occurred. So that's one aspect. Now there's more missed days. So the parent is now stressed or even more concerned about, financial resources. Then if there is a sick child, right, that parent feel stretched if there's other children in the home that may not have that attention. I think oftentimes we think about caregiver burden for like adult children, if I use that term, like taking care of their parents, but that is the same as a parent or a caregiver taking care of their child. And we know, right, that worsens physical health outcomes, mental health outcomes. I can't tell you, I'm sure Dr. Freeman has stories of, I've seen a caregiver bring a child, for a visit and they themselves are sick and are not able to attend to their own health. They've had missed appointments. I see this even for infants, Dr. Freeman, I'm sure you do, right? They're coming in for their 1 month appointment, and the parent that's delivered has not been able to get to their OB appointment for follow-up. And they're, a birthing person that, may struggle with hypertension and we have concerns for preeclampsia. And then now they're suffering worse outcomes because they're focused on the health of their child. And so again, this is going to be a downstream, trickle effect. It won't be a trickle. I mean, it's going to be a tsunami, right? Children are sick. We're going to see adults getting sick. And then that's going to not even just worsen the caregiver burden, but the outcomes of adults as well.
I agree 100%. I think we're going to see it a person to person level. We're also going to see an economic impact to that. So parents, I've had a number of parents who their child is sick, their employer, either the FMLA paperwork wasn't done or they didn't qualify it because of the amount of time. So they lose their job. So then you have this economic burden on the family as well. This can turn into whether it's food insecurity, housing insecurity. I think could be a deterioration in terms of the infrastructure that we have for our society. I think it's a really scary time. Pediatrician, there are two things I'm scared of right now. One of them is what's happening with Medicaid. The other one is measles. But, I think there are really critical things that are impacting our society. And it's really important that we understand and reflect on what this could mean, whether before policies move forward.
Thank you for that. I think this discussion has been really enlightening and brought up so many great points, and it really depends on all of us to be strong advocates. When you get into healthcare, the goal is to save lives and help as many people as much as possible. But part of that is figuring out how to raise our voices so we can elevate others. And it's extremely important that there is going to be a significant domino effect with Medicaid cuts and just federal funding cuts across the healthcare landscape. Right now, there was a report 2 weeks ago that's showing that healthcare is the largest employment sector in the country. So when you have majority of people working in the employment industry, in the healthcare sector, starting to lose jobs, that's going to have a huge economic burden. Healthcare is the #1 employer in most states right now, and it's just continues to grow. So we not only need to continue to advocate for all healthcare services, but also supporting healthcare professionals as they are dealing with the tough times of seeing patients that they want to help, but they're not able to help. It takes a lot of patience and a lot of mental anguish that you have to overcome to deal with the distress. We learned from COVID that seeing the chaos as healthcare providers across the country, you have to take time to heal yourself before you can heal others. So it's an important reminder that the work is not done. We have to continue to be strong advocates. And, keep showing up, write to your local elected officials, write to Congress, really share your voice so that people can really understand from a human perspective how this impacts. We are more than numbers. We are real people, real community members that we have to be vocal and making sure that our voices are heard. So with that, I'm going to pass it off to Brandon to close out. Thank you, both Dr. Maspy and Dr. Freeman, for a wonderful presentation.
Sorry. Well, yes, thank you so much. I'm learning more each. This is, I think, my second time just at least speaking to him about this and learning a great deal each time. So I really appreciate it, and I appreciate the work. One thing I didn't mention is that the three of them are all 40 under 40 winners from 17, 18, and 19. So we have obviously the candidates we get and the classes that are selected are just all amazing and do work. And we'll be welcoming our next class, which is our 10th class. So now we have 400 of these guys walk around around the world now that have been great advocates in minority health or health in general. So congrats to them for their accomplishments in the past and future, and then our next class. And if you have the opportunity, please join us at our annual summit, where you'll see these guys are the younger versions of these guys that get honored April 28th and April 29th. So thanks for everything, and we will see you guys next week.